Well, greetings, everyone. It's the top of the hour, and so we are going to go ahead and get started. We'd like to welcome everyone to the American Medical Association's Professional Satisfaction and Practice Sustainability webinar series. Before we begin, we want to quickly review some housekeeping items. This session will be recorded and will be available after the event. So if we don't get to all the questions, we'll try and address them there. If you do have questions, please place them in the Q&A. We will try and get to all of them. And if we don't, again, we'll try and address those at the end. So without further ado, let's go ahead and get started with today's webinar. Our speaker today is Dr. Mark Greenewald, who's the professor and vice chair in the Department of Family and Community Medicine at the Carilion Clinic and the Virginia Tech Carilion School of Medicine. Today, Dr. Greenewald will be presenting No One Should Care Alone, Creating Processes for Intentional Professional Connection. Welcome, Mark. It's a pleasure to have you with us today. And so I'm going to pass our virtual microphone and presentation over to you.
Thank you, Dr. Rohak. It's a pleasure to be here and an honor to be here. And I want to thank everyone for carving out some time to spend some time here together, talking about something that I think is really vitally important as we continue this conversation about professional satisfaction and sustainability. So I've called this No One Should Care Alone, and we're going to be exploring together this whole idea of professional connection and how we can become much more deliberate about it, or what I'd like to call creating professional cultures by design. I want to start out by actually a question that I believe was put into your chat, and that is that why is it important to not swim alone? Now, that may be an unusual way to start a talk, but one of my favorite things that I like to do to stay healthy physically is to swim. And prior to COVID, I swam at least 3 times a week. And one of my favorite parts of it, I swim at the YMCA here, and one of my favorite parts of swimming is to watch the new children's swimming classes as they begin, because the instructor will always ask this question. He will say, why is it important to not swim alone? And I love to watch all the faces of the children, because invariably 2 of the responses, the first one will be, so you don't drown. This is, I love, of course, very, very important. Do not swim alone because you don't drown. But then somebody will always say something to the effect, because it's more fun. So why should we not swim alone? First of all, so we don't drown. And secondly, because it's more fun. Which leads into the direction that we're going to take today. It was just last week that I ran into one of our critical care unit clinicians outside of work. And I had just recently been in touch with the section chief of our critical care division to check in to see how things were going, because not unlike probably what's happening for many of the attendees here today, we're in a COVID surge right now, and our hospital has censuses that are higher than they've ever been, not just for our hospital, but for our outlying hospitals as well. And so running into this particular clinician outside of work was refreshing. And I said to him, I said, I understand things are going very well after talking to your section chief, that you all are hanging in there. And he said that you're really supporting each other and really doing a good job of helping each other get through this together. And he looked at me and he smiled and he said, yeah, we are. And then he looked away and he said, but it's been rough. He said, you have no idea what it's been like. And I paused for a moment and I thought, you know what? I don't have any idea what it's been like for you to be in the critical care unit. I'm not a critical care physician, but I know what it's been like to be navigating through this journey of COVID. And I know what it's like to be a professional in healthcare in 2021 and through 2020. And here's what I do know is that no one should be trying to traverse what's been happening in healthcare alone. So just like our friends at the YMCA, there are 2 reasons why we should not care alone. The first is so we don't drown. And the second is because it's way more fun. So question that I want to start out, this is a thought question for those who are on the call today, and that's this: what is your organization presently doing to create a deliberate professional culture of connection within your organization? So however you would define your organization, whether it's a small clinic, or whether it's a large healthcare system, or whether it's an insurance company, or whether it's something else, what is your organization doing presently to create a deliberate professional culture of connection? Again, a thought exercise that I just want you to hold on to that, because we're going to be coming back and revisiting that question again in just a little bit. To start out, though, I think we need to lay the groundwork for our time today. And certainly, it would be hard to talk about healthcare within the last few years without using the word crisis. It's certainly a word that's been used a lot. And I worry often that it's a word that almost has lost its meaning because we've used it and it's become so familiar. In Chinese symbolic language, the word crisis is made up of two word symbols. The first stands for danger, and the second stands for opportunity. And it's that way of thinking about crisis that I want to frame our time together today, because I believe that we have great danger right now that we're traveling through. And I also believe in the midst of that danger, we have incredible opportunity. Here's the danger. You all know these statistics. You've seen them many times. I worry we've seen them so often that just like the word crisis, we've become almost too familiar with them. So this was the study that was published in 2019 by Tate Shanafelt and his colleagues, doing a third of 3 national surveys that they had done over a sequential 3-year period, looking at physician burnout using the Maslach burnout inventory. And as you see here, the data were sobering. The mean high burnout risk was 44%. And you can look across all these specialties and see that it was sobering for each one of them. Even the lowest, even the least burned out specialty was above a third of their clinicians being at this place of high burnout. Here's something that I think we need to think about in terms of thinking about the perspective of this data. First of all, if 44% of clinicians are in this place called burnout, it doesn't mean the other 56% are wonderful, are thriving, are filled with joy in practice. Indeed, the data would indicate that many of them are in what I like to call survival mode. And survival mode is not the place where we want to be practicing from, nor the place where I believe our patients want to be receiving their care. And that's just about burnout. Shanafelt and his colleagues in that article also said that what we're really talking about is professional distress. And he defines distress as this multi-dimensional construct. It includes burnout, but it also includes a whole lot of other things that are collectively dragging us down as professionals and preventing us from providing the kind of care that we desire. So how did we get to this place? This is not new data. We know this. The first article that Shanafelt and his colleagues published was on 2012 data. And the number of those experiencing burnout has stayed above 40% during that entire time, and in one case, going above 50%. So what is it about our programming that allows this to happen? Well, first of all, for physicians, we don't like to talk about this. Indeed, we're selected out. We are socialized, we are programmed in many ways to create a culture where we don't like to talk about this. And it's not very comfortable to talk about. In many ways, it becomes almost of our badge of honor to not talk about this, that somehow we're stronger and we can get through it. What about our administrative colleagues? Well, if you look at that data and you were a healthcare administrator, you don't want to hear about it, because we've got important things to do. We've got patients to take care of. Right now, we have wards that are spilling out. We have emergency rooms that are backed up with patients who are experiencing COVID and other things. We don't have time to think that our workforce is struggling like that. And what about patients? What about payers? Well, they're blind to it. Because the fact is, if they really understood what was going on right now, the first question that I would be asked every time I saw a patient was, tell me if you're burned out right now, because I want to make sure that you're able to provide the kind of care that I need. And then this culture is a culture that goes deep. So this is the study that was just released by Medscape 2 weeks ago. And just the title alone is sobering. Death by 1,000 Cuts, the 2021 Physician Burnout and Suicide Report. Now, that may not become a bestseller, but the data that were contained in here are very telling in terms of just how deep this culture goes of not talking about what we're experiencing in terms of professional distress. So here was a question: how do physicians cope with burnout? Now, first of all, in this particular study, 42% of physicians across specialties were experiencing high levels of burnout by their own self-assessment. So how do they cope with this burnout? I want to just focus on one particular element that says a lot about our present culture of medicine. 43% said, I cope with it by isolating myself from others. Isolating myself from others. That got the same response percentage as talking about it with family members or close friends. So I don't want to talk about it. And then the survey went on and asked, have you ever felt suicidal or attempted suicide? 13% of the respondents said they've had thoughts of suicide, but have not attempted. 13%. Stop and think about that. But then they went further and they said, whom did you tell about your thoughts of suicide? And once again, none of the above, which I interpret as no one, got the same percentage, or actually a little bit more percentage of positive responses than I told a friend or colleague, a therapist, a family member. And so this culture runs deep. And then the question, does your workplace offer a program to reduce stress and or burnout? So our first poll question is going to be for those who are participating in the webinar today to answer that very same question. Does your workplace offer a program to reduce stress and or burnout? So you'll see the question, the poll question up on the board right now. And if you would just go ahead and enter your answer. We'll see how we did compared to the Medscape National Survey. All right, Brittany, I think I need, so 59%. Sorry, I just need to exit the poll here. 59% of our group. Wow. Now, again, think about that. This is a group that has selection bias already because we're coming to this. And again, looking at the attendee list ahead of time, many of us are coming from healthcare organizations where you would assume this is not news. So 47% in the Medscape survey said, no, we have nothing. This is in 2021. And then they went and asked an additional question, which was, how likely are you to participate in this program if there was one? 42% said very unlikely. So again, you think about all of these things that add up to, we have created a culture where we have become very, very isolated from each other. And what that's led to is what I like to consider distress 911, not only about burnout, but about PTSD, compassion fatigue. I got nothing left to give. Decision fatigue. I'm paralyzed. I don't know how to make the decisions that need to be made. Depression and anxiety, moral distress, that whole idea of I'm in a lose-lose situation. And we've heard more about that in the context of COVID, relational dysfunction. And then add on top of that what's happened over the last year, political polarization, social unrest, and economic uncertainty. And it's the perfect storm that if we had 40-some% of folks who were experiencing burnout in 2020, those numbers are just humbling now. And that leads to what I call the emotional 911. Clinicians are experiencing a lot of emotions and expressing a lot of emotions that historically would not have been proper for us. Hopelessness, anger, numbness, helplessness, demoralization, sadness, grief, rage, weariness, shame, guilt, and then loneliness. Hearing more and more saying, I'm just done with this. I'm feeling so incredibly isolated. Loneliness. So back in 2017, former Surgeon General Vivek Murthy said that he considered loneliness to be a public health emergency. And here's what he said about that. He said, despite living in the most technologically connected culture in human development, people in this country are isolated and alone. The percentage of Americans who report feeling lonely, 40%, has doubled in a generation. And we're part of that. But what about we then as physicians? So this was based on a study done by Sean Akor that was published in the Harvard Business Review in 2018. He said graduate degree holders reported higher levels of loneliness in their study and less workplace support than respondents who had only completed undergraduate or high school degrees. But then he went on to say professional degrees, law and medical degrees, were by far the loneliest, scoring 25% lonelier than bachelor's degrees and 20% lonelier than PhDs. We are a very isolated lot, we are. And then we've added to this whole idea of physical or, quote, social distancing. And we find ourselves disconnected. We find ourselves disconnected from our profession, from ourselves, from our patients, and from each other. And so the question becomes, what about that? Because we know that being connected is built into our brains. We have evolved to be connected social creatures, to the point that Mark and Frederick Southwick, who are two psychiatrists, published in JAMA Psychiatry in the spring of last year this statement: while many interventions to reduce burnout have been proposed, none is more important in our view than addressing the fundamental human need to belong. So what does it look like then to create a deliberate culture of connection? If we believe for a moment that disconnection is not in our best interest as professionals, and if we believe for a moment that the data shows that we are not naturally connecting professionally, that is not part of our professional DNA, then how do we begin to do that in a very deliberate manner? And that's what we're going to be exploring in the rest of our time together today, in doing what I call creating a culture by design. There are only two kinds of cultures in organizations that I believe. There's either cultures by design or cultures by default. And if you don't know which one yours is a culture by default. Now, the beauty of this is that a culture by default doesn't necessarily mean you have a bad culture or an unhealthy culture. It just means that if things go wrong in your culture, you have no true north. You have no roadmap to reference back to get back on course again as your culture. And so how do we create this connection culture? John Fry, who's been one of the stalwart leaders within family medicine, talks about this in an editorial that he wrote in 2018: not valuing time with other physicians or allowing for informal conversations leads to a soulless efficiency in professional isolation that drains physicians of our ability to help ourselves, to help each other, and to help patients. That's our culture. Culture is the way a group thinks, acts, and interacts. So if we want to create a deliberate culture by design, a connecting culture by design, how do we begin to do this? Because what we know and what our management colleagues tell us is that culture eats strategy for breakfast. It's that important. It's that important. So I want to start by doing a case study in culture, your culture. So we're going to harken back to that original question: what is your culture presently doing to create a deliberate connection culture by design? So I want to just pause for a moment and give you a chance to think about first this question. If you could give 3 adjectives to describe your present organizational culture, however you want to define your organizational culture, what would be those 3 adjectives that you would use? Present organizational culture. One of the things that I hear regularly in my own culture when we ask this question is kind. We are very kind to each other, which I think is a great thing. I think kindness is a good thing. But often hidden in that is something else, which says we are kind, and because of that, we are not something else. So the second question for your case study is this: what would be the adjectives that you'd like to describe for your ideal culture by design, connection culture? What would that culture look like? And how would it be different than that present culture that you're living in right now? We're going to take a look at this through a survey that I created and published a few years ago. And just as a disclaimer, this is not a validated survey. This instrument was created as a way to catalyze conversation within organizations around what I consider to be some important attributes of a well culture, of a culture of wellness. And I called it being a 5 stars connection culture. And STARS is an acronym. It stands for service, teamwork, attitude, reflection, renewal, and self-care. And when we're talking about this, we're not talking about our patients in this particular case, because when we talk about service, obviously we traditionally talk about service to patients. Well, what does service look like? Not to our patients, but to each other. What does teamwork look like? Not in order to provide care for our patients, but in terms of what a teammate would be doing for each other. Attitude has to do with the attitude I bring to my team. Reflection, renewal, and self-care. And so what we're going to do is I'm going to take you through some of the questions that are on this instrument, and we're going to use some poll questions to see with the group who's here today how your connection culture is right now. And here is the rating system that we're going to use. And in a moment, we're going to have the first poll question up. So never, rarely, sometimes, often, or daily in the last week. So for the first question around service, in the last week, we recognize our teammates for their good work, however you would define that, from never to daily. So let's go ahead and put the first poll up, see how we're doing. All right. Very good. So often, but not necessarily daily. So again, I want to pause for just a moment with the group and just say, all right, think about whether we think that would be a good thing to recognize our teammates for their good work. And if we're not doing that daily, particularly in the time of COVID, what's the cost of that? What do people take home with them for the incredible work that they're likely doing every day if we're not creating a culture where that just comes naturally? That's just built into our DNA. So let's look at the next question around teamwork. We check in with our teammates and know about their joys and their struggles over the last week, never to daily. How are we doing? All right. So once again, as you look on that, lots of room for improvement. Now, here's the interesting thing about this question. And when I first created this survey and started sharing it with our team, I was humbled to start learning some things about what people bring to work every day that I was totally blind to before. I learned about one of the nurses on our team whose husband that particular day was undergoing treatment for cancer, and she, in this case, was at work. I've learned about sick children being at home, parents, things that people are carrying with them when they come to work that we know impacts their ability to show up. And yet I was totally blind to many of these things before I started checking in with folks. And they bring great stuff as well. But do we know about that? Because that makes a difference in terms of how we do in any particular day, how we do our work. So let's take a look at the next one. Attitude. We helped to create a positive and encouraging team culture over the last week, never to daily. And let's take another look, see how we did. All right. So better there, moving up 80% or so, or often or daily. And so that's a great thing to see around attitude, that we're creating a culture of encouragement and a culture of positivity becomes even more so as, again, we navigate COVID. What about reflection? Over the last week, we regularly connect with those things that have meaning in our work. And let's take a look at the poll and see how we did. All right, we're spread out all over, but God sometimes seem to hit the medium. Regularly connect with those things that have meaning in our work. Again, think back, Christina Maslach, when she talks about burnout, she created the Maslach Burnout Inventory. She said that ultimately, when someone's in a state of burnout, they're experiencing what she calls an erosion of the soul. And I like to think about our work in healthcare as being soul work at the end of the day, about meaning, it's about purpose. And so regularly connecting with those things becomes essential if we're to be able to carry out our mission in terms of the work that we do. What about renewal? Over the last week, we take time to celebrate our successes from never to daily. Let's see how we're doing as a group. All right. So, again, pause for a moment. 50% of those in attendance right now say we rarely take time to celebrate our successes. Again, pause for a moment and think about the implications of that in the context of the incredibly challenging work that we're doing right now, and the need more than ever to be helping to try to fill each other up, as we have a lot of things that are withdrawing from us emotionally at this point in time. Finally, how about self-care? We take time for stress reduction and relaxation. So over the past week, as a team, never to daily. All right, and if we add that up, half of us say rarely or never. So again, think about that in terms of the work that we're presently doing, many of which people are working harder than they have in a long time. And we were working hard at baseline, but the hours that many people are putting in are unthinkable 1 year ago. So the need for some kind of reduction in stress becomes even more so. And if we're not carving out time for that, where's that happening? Is it happening? And if not, what are the implications of that? So how do we then create a connection culture? That's what we just demonstrated, is that's our present baseline culture. And that's okay, because that's just facing the reality of where we are right now. But what would it look like to create that culture of connection? Well, the first good news is we've got some secret weapons. And those secret weapons are our relationships with each other. And those relationships in many ways are untapped right now. So what could it look like to begin to create this kind of culture that is supportive, that is really the kind of culture that deliberately connects us together? And what I want to do is just share with you a layered approach that I think might be helpful to many of you in terms of beginning to think about that. Now, traditionally, we're going to start at the top of this pyramid in terms of those things that we want to make sure that we're addressing for everyone in terms of what's available. And that'd be some kind of crisis hotline, some kind of crisis mechanism to be able to, for our clinicians to know that if they're in trouble, there's a place that they can call, that the answer doesn't have to be, I have to think about taking my life as the only possible avenue to dealing with the emotions that I'm dealing with right now. So making sure that not only a crisis hotline is available, but it's socialized, that it's not something that we apologize for, but we recognize that, my goodness, in the context of the work that we do, that some would occasionally struggle should not come as any surprise to us at all. How do they know they have some place to reach out to? And that next layer then is other mechanisms for people who are perhaps not in crisis, but not doing well at all. They may be burned out. They may be experiencing some other kind of distress. They may be in survival mode. Traditionally, we have EAP, and EAP is one possibility for many folks. My experience and my challenge with that historically has been that many of our colleagues don't look at EAP as an avenue that they feel comfortable with for multiple reasons, that they feel exposed in the context of that. We have second victim programs, and I know that Joe Shapiro has been here to talk about peer-peer support around this phenomenon called second victim. When some bad outcome happens, what about those people who are involved in that bad outcome beyond the patient and their family? Who would we consider the first victims of that? And how do we reach out proactively to support them in the process of doing that? And then making sure that we socialize other mental health resources perhaps that are in the community that are beyond an organization, so that clinicians have other avenues if they don't feel comfortable in reaching within an organization for help. And then this third layer that I'd like to talk about is things like support groups. Are there support groups that are available for people just to reach out to? Within our own organization, we call those express groups, as a way for clinicians to come together and just talk about what's going on in their lives. Some of those in other organizations are much more deliberate. Some are theme-based to allow physicians to come and talk about things. There are programs for peer one-on-one support that are beyond second victim, that just say, if you're not doing well at all and you don't feel comfortable reaching out to a therapist or a friend or EAP, there are peers who are just available to talk with you, just to meet with you, to walk with you during this time of struggle that you're having. And then making sure that our clinicians are aware of other healthcare resources, that they're accessing those things that we do every day, seeing your physician, having a personal physician to be able to help walk the journey with you. And then on the next layer, there are things like just peer connection. And I'm going to spend a moment to talk about that because that's something that has been very important to me. And I created a program last year to begin to look at peer connection and how we could do that much more deliberately. There are deliberate social gatherings, which has been very, very challenging right now in the time of COVID. And actually, just last night, I gathered together with 3 of my colleagues around a fire outdoors to celebrate the fact that it was 2 weeks ago that we got our second COVID vaccine. So supposedly we are at peak antibody right now. And we wanted to just pause and celebrate that. And we realized that we hadn't done that in well too long of a time. And then wellness resources, making sure that our colleagues are aware of what resources are available to them within and beyond organizations that can help advance their wellness and well-being. And then at the bottom of this pyramid, from an organizational perspective, are who is it that's helping to orchestrate all that? Is there a well-being committee within your organization or some kind of other group that includes clinicians that are helping to design the processes, that are helping to hear where the pain points are and helping to address solutions for that? And then is there clinician leadership of that? Some organizations have created a position called the Chief Wellness Officer, but that's not the case in most organizations. And so what other clinicians are helping to lead those efforts to make sure that the needs that we've laid out so far are being taken care of? When it comes to peer connection, a year and a half ago, pre-COVID, recognizing that this was a problem, I created a program. But before that, I just want to highlight a few other professional gathering spots. One are online forums. So there's some examples like Sermo and Doximity, Mom MD has become a huge gathering spot for female physicians and moms. Quantia, finding meaning in medicine discussion groups have become very popular in many places, just to come together and talk about the journey that we travel on together. Compass groups that the Mayo Clinic has published a lot about. These are groups to get together just over dinner and talk about whatever is going on. And a lot of times there'll be a prompt question around that to help guide them. Balance groups have been something that many organizations have used. And then the doctor's lounge. It's interesting, when I started my career more than a quarter of a century ago, the physician's lounge was the gathering spot. And now in many organizations, in many hospitals, they don't even exist anymore. And if they do, they're not used in the same way. That was the place where physicians came and actually met and got to know each other and talked about their families and talked about many cases, in many instances, patients that they were wondering about. And what is the equivalent of that now for us in organizations? One of those things I believe is the equivalent of that, or at least something to begin to address that, is the program that I created called PeerRx Med. So PeerRx, for short, with the tagline, "No one cares alone." And it gets back to our original story of why is it important to not try to care alone. First of all, because you can drown. And secondly, because it's way more fun to have a buddy in the process of traveling the journey. And within PeerRx, I've created the process that I fondly call PRX 90 as a tongue-in-cheek, but also as a symbol of saying that what does it really look like to try to connect regularly with colleagues and do that in a deliberate fashion. And the check-in for PRX 90 is in as little as 90 seconds once a week. What would it look like to check in with a colleague by text, by email, by phone, just to say, how are you doing? And then once a month to check in for a longer period of time, for up to 90 minutes, but it could be much shorter than that, preferably live. And then once every quarter to check in for recalibration, 90 minutes every 90 days, just to say, how are things going? And in those gatherings, to talk about weekly check-in questions. Very simple. How are you doing? What can I do to help, support, or encourage you? And then monthly check-in questions. How are you doing? What's going well? What are you struggling with? How can I help, support, and encourage you? And then quarterly check-in questions. How are you living out your values? What are your goals? What are your dreams? When's your next vacation? And how can I help, support, and encourage you? And part of the way that I've structured this process is that once a week, an email comes out to participants that I call the Buddy Check Nudge. And the Buddy Check Nudge basically says, time to check in with your buddy, and then usually includes some additional questions and a link to a blog for those who want to go deeper with that particular topic that I'm thinking about that week. Now, PRX is a free program. It's done as my mission, and it's been in process now for 1.5 years. So we've had some folks who've been traveling this journey together for 1.5 years. The feedback that we've received has been very powerful. And my vision for this is that organizations would become PeerRx organizations, where they would be encouraging their physicians to make sure that they had a buddy or some buddies, to make sure that no one was trying to care alone. So with that, I want to pause again and pose the question that I asked in the beginning, but pose it differently. Based on our time together, what might you do differently to create a more deliberate professional culture of connection in your organization? I want you just to ponder that, because in a moment we're going to open up to questions, and I want to make sure that we have an opportunity to really spend some time in dialogue. Here's some additional resources that you might be interested in if anything today piqued your interest. Two articles that I have written and published in Family Practice Management about creating a culture of well-being, and that has the full instrument of the STARS instrument in for both individuals and for teams. And then the Creating Intentional Professional Connections to Reduce Loneliness, Isolation, and Burnout was an article that I authored that was published in September of this year that gets more into this whole idea of professional connections. And then the article by Southwick and Southwick about the loss of social connections as a major contributor to burnout, which is a 2-page article that's worth reflecting on if you hadn't thought about that before. So I want to pause now, and I want to hand the microphone back over to Dr. Rohack, and hopefully to open up the dialogue to talk a little bit more about this whole idea of connections and culture by design.
Thank you, Mark. And what we want to remind everyone on the webinar, if you have additional resources and there are things that the AMA has produced to help you and your physicians, as well as your staff during this time. And that's all available at the AMA's website, www.ama-assn.org. We also want to thank you for the next slide, because tomorrow we do have we have a webinar scheduled tomorrow at 11 o'clock Central, which is going to feature Dr. Bryant Adibi, the System Vice President and Chief Wellness Officer at Rush University System for Health, who's going to present on rethinking wellness, COVID-19 and the search for meaning. And then February 11th, physician burnout, it's not a resiliency issue, with Dr. Colin West, the professor of medicine at the Mayo Clinic. Next slide. So if you have any questions, please email us at action.labs@ama-assn.org. After this webinar, you're going to have an opportunity to participate in a brief 4-question survey. We'll ask you to take a few minutes to fill it out, because your feedback is very important as we develop future programming for this webinar series. So now it's time to do some questions. And Mark, we actually had a question earlier in the chat. The question was related to dealing with colleagues. How do you comfort someone who tells you they're burned out due to COVID, being that everyone's experiencing it? How do you find the right words to comfort them?
Very, very legitimate and important question. So I think that you know, comforting I think comforting is never telling someone it's going to be okay. I don't know that for any individual. I don't know what they're going through. So I think a lot of comforting is about listening. So if you think about this whole idea of being isolated, what I find, and part of the premise for the PRRX Med program, is that if we're not traveling alone, we have a place to process a lot of these challenges that we're experiencing right now that are very real. And so the ability to listen, and often it becomes almost a confession. It becomes a time of being able to say, here's just the things that I'm going through right now. And again, if you think about the whole idea of moral injury and moral distress, some things that I'm not proud of, some things that I'm ashamed about, some things that I'm feeling guilty about, and the ability just to have a colleague lovingly listen to those things is just a gift in and of themselves. And then if you end that time of listening to your colleague and dialoguing with them, and you're still concerned about them, the right thing to do is to be able to express that and to say, look, I'm really concerned about you, and to be able to know what resources are available in and beyond your organization to help them get help. Because if we struggle, you know, I talk to physicians over and over again that we're the caregivers, not the care receivers. And yet that scripting can prevent us from reaching out for help when we do need it. And so as a colleague, being able to disarm that whole mystique around not seeking help can really, I think, be a gift to our colleagues. And what we're seeing happening, I just saw this recently, is some of our senior leaders in organizations are starting to share stories about the times that they weren't doing well and reached out and sought help through therapy, through other means. And I think that begins to disarm the conversation as well. But on a one-on-one level, again, I think just listening and letting them know that you care, and letting them know that it matters, and letting them know that they're not, first of all, they're not weird, because if they're feeling burned out right now, they're almost the majority. And that it doesn't have to stay that way for them.
And I think it's interesting, a couple of comments that were made in the chat earlier, that the 5% of people who preferred not to answer in the suicide, they probably were thinking about suicide. And your PR90 program of checking in, you know, when you check in with a colleague, it destroys the myth of, hey, we're all invulnerable and we don't have any problems at all, and we go through this. So One of the questions, and then we'll get to the questions, one of the last comments in the chat room was, how do you sell connection and creating a safe space when you're dealing with trying to bring people together?
So how do you sell connection and the safe space, or
No, how do you sell, quote unquote, how do you sell connection
yeah,
and create a safe space?
yeah, great question. Thank you for that. So I would say that creating safe space is going to look different for different people. First of all, that what I find is that for some people, safe space is going to be one-on-one at best. That the idea of getting together in a larger group, particularly if they're feeling vulnerable and if they're not feeling good about where they are professionally, is a real challenge. What I've seen in our own organization is, again, we have the same culture of medicine that I just laid out that everybody else has, is to begin to get some opinion leaders to both participate in the process and to start to share their stories. So as people start talking about, as our leaders, as fellow clinicians start talking about both the importance of connection and how they use that connection, and often also, again, without them telling stories that are not real, if they've ever struggled, what they did about that to be able to navigate through that struggle begins to disarm the conversation. So that, I don't expect it to all happen at once, that all of a sudden everybody says we need connection, and even though I think we do, I don't see everybody buying into that. I see we physicians are cautious, and so we're going to watch to see what others are doing and what results they're getting. So with the PRX program, what we've seen are people who are participating in the program sharing that with people who are not, and saying, here's something that I'm doing that I found really helpful, and their colleagues then check it out, and that becomes a process that it just organically grows.
So to follow up with a question on that, Mark, when you're trying to create a more professional culture of connection in the organization, what's kind of the first steps to get it going? If you use that pyramid approach, which bar do you start with? How would you suggest to the listeners?
Yeah, so what I would say is you have to start by making sure, first of all, that there's a lifeline. So you got to start at that top part of the pyramid to say, do you have a crisis hotline that people know about, and don't stop there. So what I would like to see, my vision is that professional well-being committee, whatever you have in your organization, is thinking about that entire pyramid and saying at each level of that pyramid, what do we have in place now, and what is missing, and beginning to look at that. So I would say, again, thinking about, I always think you want to go reactive and proactive at the same time. And so thinking, okay, reactive, so even the second victim. So even second victim is a little bit reactive. It's proactive, reactive. So a bad outcome has happened. So now we're reacting to that by being proactive and reaching out. I think that's essential. You still have to look at where people are swimming right now alone. Mm-hmm. And once you get past that, beginning to think proactively. So what about the rest? What about the rest who are in survival mode? They haven't had any bad event happen yet, and yet we know they're still struggling. And so I think thinking about it multi-layered becomes important. And again, if you think about the resources for some of those things are not that great. So you don't have to wait for the new budget to come out. You don't have to wait for permission. You can just start rolling things out. The other thing that I find, Jim, is that getting down into microcultures becomes really important. So not just thinking, I'll use my organization, what is Carilion Clinic doing for this? But what's happening in the Department of Orthopedics? What's happening in the Department of Medicine? What's happening in the section of cardiology? Because that's where opinion leaders are really going to make a difference. And so not surprisingly, in our own organization, we see some of our departments who are much more active around creating well-being resources and creating well-being structures and connections than others. And so what we're trying to do is learn from that and say, okay, if it worked over here, now how can we take it over to this department and translate it over there? And that's where we've created an ambassador model so that members of our committees are ambassadors back to their own microcultures, and they can speak that language better than I can.
So in an environment that tends to be a physician-centric or physician culture, how do you get physicians involved? Do you find that the best ambassadors are physicians that have been burned out and are now saved, similar to AA?
Yep.
what's your experience and your suggestion?
Yeah, and I think a little bit of both. I think we all have burnout stories, to one degree or another, and so I don't think you have to go out there and find somebody who's crashed in order to do that. What I find is what I see is a blend, because often what happens is the people who step up and want to be part of that are the go-getters, which I love.
Mhm.
But some of them, and I would include myself, and so I'm always doing a check on myself around this, because I tend to be a glass half full person. Am I in touch with my colleagues who are struggling? Have I just got some, come on, let's just be happy, and making sure that I'm checking in with them regularly and saying, am I missing something here? So if you have the folks who aren't necessarily, you don't want folks who are burned out at the time. Those are certainly not folks who are going to be helpful. But knowing people who are in touch with their own journey, their own struggles, and their own story, I think can make a huge difference. And then getting, so I think it's very important, again, in our own organization, to have buy-in from the physician leadership. So our physician leadership being our CMO, our clinical chairs. Without their buy-in, it's going to be hard at the culture level of a department to really gain any traction. So having a physician champion who is not a chair, but then having a physician champion who has the ear of the chair becomes really important.
Do you, in the recent issue of Academic Medicine, Daryl Kirch,
Yeah.
mentioned about his challenges. Do you find, at least in your experience, that having those leaders, the chief medical officer, the CEO, open up about their humanness and their challenges, to emphasize that, one, yeah, we're all human, we've all been through it, but two, there is a light at the end of the tunnel, and here's the resources we're providing for you as an organization. Has that technique been effective, do you think?
I think that adds credibility. It is interesting. I read Dr. Kirsch's essay, and brought about many things for me, because I've heard him speak before, and I love that a national leader is doing that, and I still believe it needs to translate down to the level of the organization, and so yes, absolutely. The more, and I believe this in general, the more our leaders can express the fact that they are human, not as a sign of weakness, but as a sign of wisdom, I think the more we're going to be able to change the conversation and create these cultures of support. Because again, the dominant culture right now within healthcare is not a culture of support, but it's a culture of autonomy, and it's a culture of armor. And so how do we get past that? We get past that by the people who are respected beginning to take off their armor. Right. is the best way to think about it.
Have you applied any of the narrative medicine approaches to improve the clinician experience? And if so, could you speak to some of the challenges and benefits?
So some of our different groups, our microcultures, have done that.
Right.
We've done that some with our residents. So for those of you who are not familiar with that, so the narrative medicine is just taking some time to actually write about your experience. I'm involved here with our healing arts program. So we've been looking at that, not just from a narrative medicine perspective, but more broadly to say, how do you use all of the different arts as a way to do that? There's something that actually my CEO just sent me yesterday that's called the theater of war. And some of our attendees may be familiar with this. So this is a national organization. They've caught a lot of traction, gained a lot of traction in the emergency medicine community, but they're actually using some of the Greek classics as in theater as a way to get access to some of the things that we struggle with that we're not able to necessarily get access to just head on. And so the ability to watch a play or listen to a play and then say, wow, how does that translate to the work that I'm doing? So I think that the arts in many forms are a powerful way to do that. And again, with any of those, Jim, what I found is one works for some people and not for others. So I'm never a one size fits all.
Right.
But I do love the concept of reflection and any mechanism that can be used to allow us to step back and reflect on the work that we're doing and to see it through the eyes of the challenges that we face and to be able to be honest about that, I think is a great thing. And so narrative medicine is certainly one avenue for that.
So the PR90 program that you mentioned, do you have any? You've mentioned it's been around less than 2 years, I believe. Do you have any results? And second, does the individual who's calling, do they have to have any additional training or expertise? Because certainly you can open up a Pandora's box.
Sure.
If you say, how are things? And they say they ain't so good and
Absolutely.
thinking about
Yeah,
killing
so the way the program is structured, so I do not collect data. I do that specifically. I know how many people are participating, but I know I do not, even though I have access to that information, I don't go there because I want people to feel safe. So the way the program works is essentially you pick a buddy. So it's not assigned to you. So for me, one of my buddies is my chair. And so he and I have traveled the journey many years together. So you basically just go to them and say, hey, I want to participate in this program. Do you want to do it with me? You just sign up. It's very simple. And then once a week, you start to get these emails, and the emails they go to everybody, and you just take yours. What I do with mine is I immediately forward it to my buddy and say, buddy check. And I just say, how are you doing? And so it's really that simple. So the question then you ask of, is there a risk of uncovering things? Well, hopefully this is somebody you already know, at least on a social level. So it's not therapeutic in that way. The intention is never, I'm not substituting as even a peer advisor or peer supporter. I'm truly a peer. We're going swimming together. And so of course, as part of that swimming, we're going to experience some struggles. And hopefully we're also going to have some fun. And so that's really the purpose of PRRX is that whole spectrum. And so things come out and they navigate them. And they talk about them, and then they hopefully do what we talked about earlier, which is if somebody needs help, we get them the help that they need.
So on your wellness committee, when you're trying to create that cultural connection in your organization, right, to the whole organization as care team, do you use that initial mechanism to add then nurse practitioners and frontline clerks and housekeeping and everybody else? Is that the fulcrum, or do you have another suggestion?
Thank you. Very important question. Different organizations do it differently. So we're actually in the process in my own organization of a transition. And what we're trying to do now is we had what we called a faculty vitality and professional well-being committee. So it included, its main emphasis was physicians, but it also included nurse practitioners, physician assistants, psychologists, and others who were faculty at the medical school. So that was kind of the inroad there. We are now expanding that. So we've just created a well-being council for our whole organization. And that's now bringing together representatives from all the different aspects of the organization to try to take a more organizational view. I don't see the two as being mutually exclusive. I think you can have a group that focuses on physician pain points that feeds then into the organizational council or the organizational group, because the needs are different. The needs of, we've already seen this in our organization, the needs of our nursing colleagues and the needs of physicians are different. The pain points are different. And again, then you get into microcultures, the nursing needs in the ICU are different than the nursing needs in home health. And so all those things become important. So it's a both and.
Right. Well, Dr. Greenwald, this was great. I'm going to take the moderator's prerogative to make two observations. The first observation is I think it's our physician process that makes us lonely, because you apply as in to medical school as an individual, you are ranked as an individual, you try and get into residency as an individual, everything is very individually based. So the concept of isolation versus practice in a team, people talk about it, but that's really not what the culture of 10 to 20 years of training is. And then second, there used to be a gathering spot of physicians to provide beyond the doctor's lounge, and that was the County Medical Society. The County Medical Society used to be once a month, you have a meeting, you talk about what your community needs were, you brought together different specialties. The County Medical Society now is not as, it varies geographically where you are, but the gathering spot of bringing together peers to commiserate, to talk about life and the struggles, but also celebrate successes. I think we have lost that as a profession. And now it's a matter of, okay, what do we do next? So we want to thank, again, everybody for being on this. We look forward to seeing you in the future on future webinars. And Mark, Have a wonderful day. Your words of wisdom really linked home for all of the participants, and round of applause for you for a job well done.
It's an honor to be
Thank
here,
everybody.
and thanks to everybody.